Right. A very good evening, all of you. Welcome to our 11th case-based discussion. So I hope everything is streaming fine. If you have any issues with streaming, do let me know. Right. So in today's case-based discussion, we'll deal with another case or context and related questions. Also, we have some homework questions. Audio seems to be working fine. So also, we have some homework questions, and I'm sure you're going to enjoy doing the same. So before we start, as you know, the objectives of the session, if learning is not fun, then what's the point in doing it? Learning is fun if it is done in a proper way, it is done with right orientation. So always keep that in mind. And before you attend any session or before you attend any class for that matter, offline or online, there is always something which you can learn from that particular experience. It can be academic or it can be even non-academic. If you're learning at least one point relevant to either academics or non-academics, then the objective of attending those sessions is always fulfilled, isn't it? So always have that perspective. And once you have that kind of perspective and orientation, you'll consider each and every experience as unique, and you'll be more conscious while dealing with that particular experience. So without much delay, let's go ahead with today's case-based discussion, session 11. We've entered into our third week. So here we go. So if this were an offline classroom, then Hrishikesh would be the first person to enter into the class. I really appreciate your enthusiasm, Hrishikesh. I think Hrishikesh has been consistently commenting first in almost all the live sessions. It's like he's ever ready, waiting for these sessions. I really appreciate your enthusiasm, Hrishikesh. Keep it up. So before we start, we have the following courses going on at ptpdacademy.com. You can find all the details at ptpdacademy.com. And in fact, this is one of my favorite exercises. Before I used to present anything, it can be offline or online presentation, I usually start with a quote. But nowadays, I'm skipping this part. So I thought, like, why not reintroduce it from today? So let's start with a quote. Comparison of modern day evil. So let me be as brief as possible. If you carefully observe like what's happening out there when it comes to preparation or when it comes to so-called success or when you observe others' achievements, we often resort to comparison. I mean, we idealize people, we wish our lives were like theirs, and we start comparing to such an extent that it creates a lot of stress, it creates a lot of anxiety, it creates a lot of suffering well within us, because of these irrelevant or nonsensical comparisons. I'm using these words very carefully, irrelevant and nonsensical, because even if we take an idol, even if you take a model, and if you want to lead their lives, it only means that you're undermining your very own life. Often these comparisons arise because of the fact that in our society, we were not told to celebrate our own life. In fact, we often hear that, yes, be like that, be like this, try to achieve like him, try to achieve like her, right from schooling, right from our undergraduation, right from our childhood. We are often told like you have to be like that or you have to be like this. We were never told to be ourselves. We were never told to enjoy our own life according to our own rules. So comparisons are something which are pushed into our mind at subconscious level, right from the beginning of our journey. And this very comparison, once we, start entering into society, once we start observing many individuals, because of this wrong orientation, we start comparing and make our lives hell. As simple as that. As I said, this happens because we are often never told about enjoying our own life, enjoying our own achievements. Rather, we were told to be like someone, to be like him or to be like her, which is very unfortunate. But Keeping all this aside, if you carefully observe, each and every one of you, each and every one of us is unique and special in our own way. It's not about, are you going to be successful like him or her? Instead of those kind of questions, if you can ask this very basic question like, are you actually tapping into your potential? Are you actually giving your best? If you have answers to these questions, then all of this is nonsensical and irrelevant. You need not compare your performance with others. You need not compare your life with that of others or others with that of yours. So this is all irrelevant and nonsensical, because at the end of the day, you have to lead your own life. We all have to lead our own lives in a way which gives us more joy and satisfaction. By comparing ourselves and by trying to mimic others' lifestyle or others' activities, all that remains is a shallowness, a kind of shallowness well within our life. So my point is, do not worry about others' achievements, do not worry about others' progress, do not worry about how or what others are doing. Rather, enjoy your own life, enjoy doing what you love, create your own rules and define success instead of looking at these ready-made, tailor-made definitions. You have this amazing opportunity in this life to create your own definitions, isn't it? So all I would say is, do not resort to any kind of comparison and keep asking yourself the following questions if you wish to succeed in your own life. Are you giving your best? And are you tapping into your potential? Because as I said already, each and every one of us is unique in our own way. So with these introductory comments, let's go ahead with our case-based discussion, right? Yeah, so this is the case or context we have. So you can see, again, a 46-year-old woman was admitted to hospital in a confused and semi-conscious state. Clinical examination reveals tachycardia, tachypnea, low blood pressure, poor skin turgor, and her breath had fruity odor, smell of acetone. Laboratory investigations reveal the following. The blood pH is around 7.2. It seems very close to the normal range though. Plasma bicarbonate, 11 millimoles per liter. You can find the normal ranges in the brackets, not in bold. Random blood glucose is around 420 milligrams per deciliter. Urine sugar. So there is presence of sugar in urine, 3+, urine dipstick. Urine ketone bodies also positive. So you can see that there is heavy loss of sugars and ketone bodies in urine. That is glucosuria, glycosuria, and we call it as glucosuria and ketonuria. So these are evident with these laboratory investigations. So if you observe the keywords or key areas or hints which are going to help you answer this question. The patient is in confused or semi-conscious state. That is, her conscious level seems to be altered, neurological issues. And also she has tachycardia. She's presenting with tachycardia, tachypnea, low blood pressure, indicating maybe loss of volume of, loss of fluid from the body. Poor skin turgor, that is the elasticity. It's an indication of dehydration, obviously. Her breath had fruity odor. You know, acetones, the smell of acetone. And also you can see acetone, ketone bodies being excreted in urine. So all of these are pointing out towards what? So you have the following laboratory investigations. Even though we say the blood pH has a range of 7.3 to 7.4, there are so many buffering mechanisms which actually work 24/7 relentlessly to maintain this blood pH, and any minor deviation from this given pH can lead to range of derangements. It can be metabolic acidosis, metabolic alkalosis. We even have respiratory acidosis, respiratory alkalosis, and there are so many infections, disorders, which can lead to this altered blood pH. So in this particular case, you can see that blood pH is around 7.2, which is closer to 7.35, by the way. Plasma bicarbonate seems to be low. Random blood glucose seems to be high. And as already we discussed prior, sugars and ketone bodies are being excreted in urine. So I hope you got the context. Now let's go through the questions. First and foremost question, what is the most probable diagnosis? So which one do you think is more appropriate answer? Diabetes mellitus, metabolic alkalosis, diabetic ketoacidosis, all of the above. So which one do you think is more appropriate answer? I'm really glad to see that some of you started even answering questions even before posing the questions. I mean, this is called intuition. Okay, right. A very good evening, all of you. Yeah, you have so many hints which will point out towards certain things. Very good. So what is the most probable diagnosis? As majority of you have rightly chosen, very good, diabetic ketoacidosis is the right answer. So we have so many hints pointing out towards the same. So let's again get back to this context and look at those hints. So in case of diabetic ketoacidosis, there is altered mental state, confusion or semi-conscious state, comatose, coma also is possible in extreme cases. And also there can be tachycardia, tachypnea. It's a kind of compensatory mechanism, which we'll try to discuss a bit later. Low blood pressure, hypotension, indicating dehydration, loss of fluid from the body. We'll discuss the reasons for all of this. Poor skin turgor and breath had fruity odor. So these are some of the characteristic features, right? And laboratory investigations clearly reveal that it's a case of acidosis because the pH is below the normal range of 7.35. That is, you have around 7.2, so acidic pH. And plasma bicarbonate is low, which means because of this acidosis, because of this metabolic acidosis due to diabetic ketoacidosis, the bicarbonate ions in the plasma are utilized to balance, and as a consequence, their levels are dropping. So you have this beta hydroxybutyric acid and esteroesteric acid. So these are produced in larger quantities in case of diabetic ketoacidosis. We'll discuss the pathophysiology a bit later. So these dissociate into H plus ions, and these H plus ions combine with bicarbonate. And as a consequence, the plasma levels of bicarbonate drop, as you can clearly see. Since we're talking about diabetic ketoacidosis, one of the important features is increased blood glucose level. Even though the normal random blood glucose is less than 130 milligrams per deciliter, in this particular case, you can see how it is skyrocketing to almost 420 milligrams per deciliter. And because of overproduction of ketone bodies, they're being lost in urine, ketonuria, and because of poorly managed diabetes situation, you can see enhanced excretion of sugars through urine. So we'll discuss the pathophysiology, the reasons, and also in brief about diabetic ketoacidosis in a very short while. But before that, I wanted to answer the next question as well. Yeah, so option C is right answer. Do award yourself +4. Well done. Second question, hallmark of diabetic ketoacidosis. In fact, you have several hints previously. I'm sure you can answer this accurately as well. If you do so, then we can go through some relevant information. What is the hallmark of diabetic ketoacidosis? Is it hypoglycemia? Is it euglycemia? Or is it hyperglycemia? Or there is nothing like, there is no relation to sugar levels? What do you think is more appropriate answer? Yeah, hallmark of diabetic ketoacidosis, as we have been discussing, because of poorly managed diabetic situation. See, it can be seen in case of either type 1 diabetic patients. Mostly it is seen in case of type 1 diabetic patients because of lack of insulin production. Also can be seen in type 2 diabetic patients. But even though it is rare, it can be a possibility even in case of type 2 diabetes patients. So in case of diabetic ketoacidosis, as the name itself indicates, it is associated with diabetes mellitus. And you can see ketoacidosis. Because of lack of insulin, there is enhanced lipolysis. We'll discuss the mechanism. There is increased free fatty acid release from the fat tissues, which undergo beta oxidation in the liver, and then there is formation of beta hydroxybutyrate and acetoacetate. So ketone bodies are produced. So these are nothing but acids: beta hydroxybutyric acid, acetoacetic acid. So diabetic ketoacidosis. So at least if you can make out the following information from these keywords, that will greatly help you to have an idea of what this diabetic ketoacidosis is all about. And as majority of you have rightly chosen, hyperglycemia is right answer. Award yourself +4. Now let's review some literature. So diabetic ketoacidosis is characterized by uncontrolled hyperglycemia, metabolic acidosis, and ketonemia. So along with that, there is, in fact, this diabetic ketoacidosis is considered as a life-threatening situation and is usually seen in case of type 1 diabetic patients where there is lack of insulin production. Also, rarely it can occur in patients with type 2 diabetes mellitus. Diabetic ketoacidosis is a state of relative or absolute insulin deficiency, as one of you already rightly mentioned, that is worsened by hyperglycemia, dehydration, acidosis, etc. The triggering factors for diabetic ketoacidosis include a new infection such as urinary tract infection diabetes, pneumonias, or new onset diabetes, or lack of complaints with treatment. The patient is not taking insulin properly, type 1 diabetic patient. So all of these can trigger diabetic ketoacidosis. There is still plenty of information, but before we review that, let's do it simultaneously along with the questions, right? Now let's move on to the next question, third question. So assertion and reason. Assertion states that air hunger is seen in diabetic ketoacidosis patients, DKA, short form. Reason, it's a compensatory mechanism developed to counter metabolic acidosis. So which one do you think is more appropriate answer? Both assertion and reason are true, and reason justifies assertion. Both are true, but there is no justification. One is true, one is false, vice versa, or both are false. So which one do you think is more appropriate answer? Air hunger. You might have heard of this term, air hunger. So what is this air hunger? Does it mean increased hunger for air? So why do we see this air hunger in diabetic ketoacidosis patients? Do we actually see it? If yes, why? Very good. So one of you has actually given the synonym of air hunger. In fact, air hunger is a synonym of this particular condition. Good, Sidra. Yeah. So air hunger is nothing but Kussmaul breathing. Dr. Adolf Kussmaul, way back in 1874, has observed this increased labored and deep respiration, especially in late stages of diabetic ketoacidosis. So what's actually happening here? Because of this increased labored, deep, tachypneic breathing, in fact, they say the tidal volume increases in case of Kussmaul's breathing, even though the respiratory rate might increase or remain the same. So the body is naturally trying to get rid of carbon dioxide from the body, from the lungs, as a compensatory mechanism for metabolic acidosis. Because there is metabolic acidosis being precipitated, so there is stimulus of respiratory center in the brainstem because of this low pH, leading to increased ventilation. We can consider this as a form of hyperventilation, right? As a consequence, the partial pressure of carbon dioxide drops in alveoli. Carbon dioxide is being pumped out of your system as a compensatory mechanism for acidosis. Because carbon dioxide in blood, bicarbonic acid, you know the physiology, right? So as majority of you have rightly pointed out, it's a compensatory mechanism. Option A is right answer. Air hunger or Kussmaul breathing is seen in diabetic ketoacidosis patients. However, it's not exclusive in this situation. Air hunger or Kussmaul's breathing can also be seen in uremia, salicylate poisoning, alcoholics, etc. However, this usually happens because the body is trying to compensate. So in any kind of disorder where there is metabolic acidosis building up in the body, so the body naturally tries to push out carbon dioxide through this phenomena called Kussmaul's breathing, also called as air hunger. It appears as if the patient has hunger for air, but that's not the situation. Okay, so let's review some information related to this Kussmaul's breathing. So Kussmaul breathing, Dr. Adolf Kussmaul, way back in 1874, has noticed the same, which is labored, deep, and tachypneic breathing. So usually, Kussmaul's breathing, there is increased tidal volume with or without increased respiration rate, and it's considered as a form of hyperventilation. Stimulation of respiratory center in brainstem by low serum pH is the mechanism behind Kussmaul's breathing, leads to decreased partial pressure of carbon dioxide in alveoli through compensating as a compensatory mechanism for metabolic acidosis, is also seen in case of poisoning, salicylate poisoning, toxic ingestions, alcoholics, uremia, etc. Any kind of disorder which precipitates metabolic acidosis. Yes. Very good. Now, let's move on to the next question. So do award yourself +4. And this is one of the video clips which we obtained from Medical College of Georgia, Augusta University. It's available on YouTube. If you carefully observe, labored, deep hyperventilation. Usually in children, type 1 diabetes mellitus, one of the precipitating factors. So you can clearly see the kind of ventilation that's happening here. Hyperventilation seems labored and seems deep. So you can just check it out again. So labored, deep, and often tachypneic kind of ventilation, hyperventilation, right? So once you have this particular illustration in your mind, then you're never ever going to forget what Kussmaul's breathing is all about. Also, we have different types of hyperventilation syndromes, and we'll be providing additional information in the form of reference material in your e-classes. You can check it out. Very good. Also, in case of concealed hemorrhage, Hitesh, thank you for the inputs. Penultimate question. Commonly accepted criteria for diabetic ketoacidosis. Which of the following is the criteria for diabetic ketoacidosis to establish the diagnosis of DKA? Which of the following is the criteria? Blood glucose more than 250 milligrams per deciliter, arterial pH less than 7.3, serum bicarbonate less than 15 milliequivalents per liter. Option D, ketonuria. So which one do you think is a more appropriate answer? In fact, right from the beginning, we have been talking about diabetic ketoacidosis, hallmark features, characteristic features. We have seen the context, we have seen various signs and symptoms, also the lab results. So based on that, you should be able to answer this question accurately. You should hit the bullseye. Are you going to hit the bullseye? Let's see. Okay, very good. Very good. Rashmi, Smriti, Melija. Danish has excluded option A. Okay, let's see. Priyanka, good. Rishikesh, blood glucose more than 250 milligrams per deciliter is also one of the criteria. In fact, we have been talking about hyperglycemia, right? One of the hallmark features. So blood glucose more than 250 milligrams per deciliter, arterial pH less than 7.3, because it is acidosis, right? Serum bicarbonate less than 15 milliequivalents per liter. I want you to make a note of this point. Usually serum bicarbonate doesn't drop below 15 milliequivalents per liter, but because of increased production of ketone bodies, beta hydroxybutyric acid, ester acid, the levels of serum bicarbonate are dropping. And ketonuria, yes, because of excess production of ketone bodies, there is ketonemia, more amount of ketone bodies in blood, and ketonuria. as we have seen in this particular context. Okay, Danish, you missed out typing option A. That's absolutely fine and it's acceptable. So do award yourself +4. Those have chosen all the options. If you have chosen only one of the options, then only +1. Danish has chosen B, C, D. So only 3 marks for you. Right, I'm just kidding. So final question, it's going to be tough. Let's see how many of you are going to answer it right. Ketone body ratio in diabetic ketoacidosis is 1:2, 2:1, 10:1, 1:10. So which one do you think is more appropriate answer? As we have been talking about increased production of ketone bodies, let me give you a normal ratio. Usually, the normal ketone body ratio is 1:1. That is the ratio of beta-hydroxybutyrate and acetoacetate. Normal individual, it is 1:1. In case of diabetic ketoacidosis, there is drastic increase in this ketone body ratio, and it rises to 1:2, 2:1, 10:1, 1:10. I'm trying hard not to reveal the answer. So which one do you think is more appropriate answer? So in the meantime, let me review some information related to these ketone body ratios. So in case of acute diabetic ketoacidosis, the ketone body ratio rises from normal 1:1 to a high level, that is, you keep answering this question in the meantime. So in fact, this ratio, we're talking about the ratio of 3-beta-hydroxybutyrate to acetoacetate. And remember, beta-hydroxybutyrate accounts for around 75% of ketones, And this is rising to almost 10:1, as majority of you have rightly chosen. Very good. Well done. Option C is right answer. In response to insulin therapy, the 3-beta-hydroxybutyrate levels commonly decrease, right? And bringing back the ratio to a normal scenario, 1:1 or less than 10:1, right? Also, we have some additional information. Let me just hold it up. We can discuss it either in the next session, or the best thing I can do is I can share this reference material to you in the form of e-classes, and you can go through the same, right? So let's try to restrict to these particular questions as much as possible so that we can conclude the same in 25 to 30 minutes max. So the following are some homework questions. Sodium glucose cotransport 2 inhibitors, SGLT2 inhibitors, right? These hypoglycemic drugs can predispose to diabetic ketoacidosis. How? There are several mechanisms mentioned in literature. So check out and see if you can answer this question. Consider this very, very important, because if they give you a case-based question, also mentioning about this category of drug, then you should suspect that to be a case of DKA. And second question, what is the role of ECG in DKA, diabetic ketoacidosis? In fact, Vicoin and some of you were asking about ECG. So whenever we get a chance, we'll incorporate these questions as well, and also incorporate them in discussion. So ECG, it has a role in detecting hypokalemia or hyperkalemia. So usually in case of diabetic ketoacidosis, there is shift of potassium ions from within the cells to outside the cells. So even though there is momentary hyperkalemia, the overall potassium stores in body will be dropping because most of it will be lost through urine, right? So we'll discuss that mechanism later after this homework questionnaire slide. So what is the role of ECG in diabetic ketoacidosis? Right, I've given you a hint. It helps us in detecting hyperkalemia. It has something to do with T wave. So check it out. And third question, what is anion gap? Right, anion gap also increases in this particular context, diabetic ketoacidosis. So check it out. What is anion gap? So all of this information will be available to you in the form of reference material. But before you check out reference material, or you can do one thing. You can check out reference material, make notes, get back through mail for verification, and we'll provide you the key accordingly. I hope it's clear. Yeah, hyperosmolar state. Yeah, hyperglycemic, hyperosmolar state. That is very much possible because of loss of excess urine. There is diuresis because of hyperglycemia. See, the concept is very simple. Because of diabetes mellitus, because of insulin deficiency, it's usually what happens. What is the role of insulin? Insulin, if you consider him as Sheldon, he keeps instructing to all the organs, including liver, skeletal muscles, and the fat tissue. So what insulin does is, whenever you eat some food, as you know, the blood glucose levels rise because you're taking some fuel. So carbohydrates, whatever the fuel is, so it is converted to glucose, and the glucose levels usually rise in your blood. Now, the insulin instructs the body, right, the liver, to stop producing more amount of glucose. So there is inhibition of gluconeogenesis and glycogen lysis in liver under the mentorship of insulin. So what insulin actually is trying to do is, it is telling your liver that already we have glucose in blood. So don't release more amount of glucose. Store it in liver itself, store it in you, because we need that in case of starvation or emergency. So the point is, insulin instructs your liver to stop gluconeogenesis and glycogen lysis, right? And also insulin instructs your skeletal muscles and fat tissues to take up glucose because it is readily available in the blood, right? So this is what actually happens in a normal case scenario. Now imagine there is insulin deficiency. So obviously the reverse happens. Gluconeogenesis, glycogen lysis, skeletal muscles will be wasted, and there will be lipolysis, releasing free fatty acids into blood, which will be taken up by the liver. There will be beta oxidation, formation of ketone bodies, right? So once you understand what's happening normally, then you can easily understand and correlate that normal situations as well. So because of hyperglycemia, because of insulin deficiency, now you understood there is increased levels of sugars in your blood. And this leads to, loss of glucose through kidneys, because kidneys also will try to filter as much glucose as possible. They'll try to retain, but if the blood levels of glucose are increasing, it's like you have a cup and you keep adding more amount of water at a particular point, there will be overflow. So similarly, even in case of kidneys, if the blood sugar levels keep rising beyond a particular threshold, I reckon it's around 180 milligrams per deciliter, then even kidneys will release glucose into urine. So along with this, along with loss of glucose or sugar in urine, there is also loss of water. There is also loss of fluid, loss of electrolytes like potassium, etc. All of this create a kind of hyperosmolaritic state, as Sidra has already mentioned. So this all keeps on precipitating. It's like a vicious cycle, right? And eventually it can lead to, even a neurological deficit, loss of consciousness, and because of loss of fluid, there is hypotension. Now, if you observe the context which we presented to you initially, so all of these signs and symptoms can be justified because of this underlying pathophysiology, right? So I hope you got my point. So what is the treatment for this? Let's conclude with this. Insulin has to be given through IV infusion, and the doses they have been mentioning in literature is 0.14 units per kg per hour, right? And along with that, dehydration has to be addressed. So infusion rate has to be checked in. And also electrolyte replacement because of loss of electrolytes like potassium, magnesium, and bicarbonate as well, right? So all of this information in detail, we're going to present to you in your e-classes in the form of reference materials. You can check it out. The beauty of these case-based discussions is you're going to learn so many aspects here. And most importantly, you're not just dealing with one subject. If you observe this particular case-based discussion, we're talking about diabetic ketoacidosis. In the process, we have to learn the normal physiology. We have to understand the biochemical relevance of the values, the normal ranges, that is biochemistry. We have to know about general medicine, the pharmacological aspect, the pathological aspect, whatnot. So you have 4 or 5 subjects combined. So that's the beauty of case-based discussion. We can incorporate several subjects. We can incorporate several dimensions in a particular question, which makes learning even more interesting, right? I've thoroughly enjoyed going through this literature, and in the process, I've created these questions with the hope that they will be helpful for you in the entrance perspective. And you have any questions, you need any further clarification, always feel free to get back through mail 24/7, right? So I hope it's clear. So wish you all the best. Love you all. Yes. What do you want me to explain, Danish? Insulin is provided to the patient. Insulin is a corrective measure. So anyways, whatever question you have, feel free to get back through mail 24/7. Yeah, 180 milligrams per deciliter insulin IV infusion to fill the anionic gap. That's true. Exactly. If we can take up this format, as Danish said, we can incorporate most of the basic subjects and relevant important points as well. Okay, guys, it was lovely interacting with you as usual. I'll see you again tomorrow night at 9:30 p.m. in another case-based discussion. So check out those homework questions and get back through mail as soon as possible. Keep giving your best. Love you all.